Welcome to the Schwarzman Animal Medical Center's 10th annual One Health Conference, hosted by the Anne and Charles Johnson One Health Institute. My name is Margaret Wong. I'm a resident veterinarian in oncology at the Animal Medical Center, and I will be moderating tonight's event. This is day 4 of our conference, where we're exploring a comparative approach to cancer diagnosis and treatment. After tonight's talk, we will take questions from the audience, which can be submitted through the chat box. And as a reminder, at the end of the event, please click the link in the chat or scan the QR code to submit your form for CE credit. Tonight, we will be discussing the comparative oncology and translational aspects of breast cancer in human and veterinary patients. I'd like to thank both of our speakers, Dr. Larry Norton and Dr. Nicole Leibman, for joining us tonight. Larry Norton is Memorial Sloan Kettering's Norna S. Seraphim Chair of Clinical Oncology. He is the Senior Vice President in the Office of the President and Medical Director of the Evelyn H. Lauder Breast Center. In 1993, he co-founded with Evelyn H. Lauder the Breast Cancer Research Foundation. He is a past president of the American Society of Clinical Oncology and is a fellow of ASCO, the American Association for Cancer Research Academy, and the American Academy of Arts and Sciences. His research is broad, with more than 400 published articles, but he is best known for mathematical insights in cancer therapy and biology. Major honors include ASCO's Karnofsky and Bonadonna Awards, Columbia University's Gold Medal, and Cold Spring Harbor's Laboratories Double Helix Award. Dr. Nicole Leibman received her DVM from the University of Minnesota. She is a graduate of the internship program at the Animal Medical Center and completed her medical oncology residency at Colorado State University. She has been practicing clinical oncology for over 20 years in the New York metropolitan area. She joined AMC as a senior veterinarian in 2001 and has since conducted clinical trials and published results on the canine melanoma vaccine for both oral and digit tumors, feline oral squamous cell carcinoma, and feline breast cancer. Dr. Leibman has also studied the treatment of mast cell tumors in dogs and published several studies on staging and treatment of this disease. Dr. Leibman collaborates with Memorial Sloan Kettering Cancer Center, Weill Cornell Medical Center, and NYU Langone for teaching and research purposes. Thank you, Dr. Norton and Dr. Leibman. We look forward to hearing your talks tonight. We're going to start with Dr. Larry Norton's talk.
Thank you, folks. It's a great pleasure to be with you. I'm going to try to, I call it a lightning overview of human breast cancer, try to cover just the topic headings of human breast cancer to some degree. I'm sure many of you are familiar with much of this, so this is just kind of to lay the groundwork for the more important part of the conference, which is going to be questions and answers later. Breast cancer is obviously, a common disease. We're going to go over some of the statistics very, very briefly. My slides are not progressing. My slides are not moving forward. Let me just see. We thought we'd have like some kind of technological disaster. There we go. And I'm going to these are topics I'm going to cover, and we'll go over this, briefly. First of all, the concept of breast cancer screening, what we call risk-adjusted screening, and we'll talk about that in a second. What's the modern approach toward breast cancer diagnosis, the therapy of primary disease, and that's when most patients with breast cancer present with a lump in the breast or a abnormal mammogram in the New York City area. That's the most common way that breast cancer is diagnosed. About 5% of people are actually diagnosed with metastatic disease de novo, right from the very, very beginning. So 95% actually starts with the diagnosis of disease in the breast. And then in some cases, actually the minority of cases, it can present to metastatic disease, the spread of the breast cancer cells to other parts of the body, bone being the most common site, but really any part of the body could be involved. And we'll talk about that, and we'll talk about the therapy, very, very briefly talk about the therapy for advanced disease. There are numerous risk factors for breast cancer incidence. The most important one, obviously, is more common in women, and that includes women who are born as women, or women who become women by a trans procedure. The trans women have an incidence of breast cancer that's sort of intermediate between men and cis men and cis women. Cis men also get breast cancer, but at a rate of about 1% of the occurrence of breast cancer in cis women, and trans women are in between. But the vast majority of breast cancer that we see, obviously, in our population are in cis women. Age is by far the biggest factor in women. Breast cancer is more common as people get older. So breast cancer in young people, teenagers, does occur, extremely rare, but increases really proportional with the age of the population. I put race in quotes because I don't have a biological definition of race, even though we all know there's such a thing called racism. And race is kind of a stand-in term for your ancestral heredity, where your family came from. It's a family factor, and we'll talk about that actually in a little bit of depth in a second or two. But there are differences by your geographical origin of your genes, and we'll talk about that in a second. Having had prior breast cancer increases your risk of getting new breast cancer, but having prior um, uh, benign breast disease, that's what we call atypical, where the cells are morphed and are not quite normal, also increases your risk. Genetic predisposition is a very, very important topic right now because many of us are born into families with a high incidence of certain diseases, including breast cancer being one of them. And those families have to be identified, and those families have to be managed differently than the general population, even though the general population is still at extraordinarily high risk. With right now, 1 out of 8 American women will get breast cancer sometime in her life. Obesity is a very significant breast cancer risk factor. This is of particular importance in the United States because so many people are obese right now. It's like 2/3 or 3/4 of Americans are overweight. And this is related to changes in the diet since I was a child in the 60s. With much more processed food, it's very clear that is the etiology of it. It definitely increases the risk of breast cancer. And exercise is interesting. Exercise is independent of obesity, so that obese people who exercise still have a lower risk of breast cancer than obese people who don't. And the same thing goes for people of normal weight. This is thought to relate to estrogen exposure, your endogenous estrogen exposure, but there may be other factors involved as well. Alcohol intake is always a hot topic. People want to know what's a safe amount to drink. It is not totally clear that there is a safe amount. It may be that even small amounts of alcohol increase your risk, but by a very small amount. When you get past 7 drinks a day for your average sized woman and 10 drinks a day for your average sized man, that's when you start to get an increase of cancer that's associated with the alcohol intake. So a moderate amount of alcohol intake may, and it's not even clear, may increase your risk a little bit, but not enough to really make a dramatic difference. So somebody who's having 3 or 4 or 5 drinks a week is unlikely to raise their risk by any statistically significant degree. Prior radiation exposure, that's usually from therapeutic radiation, like for treatment of lymphomas, not from diagnostic radiation, no evidence of that. And so people who are worried about getting radiated when they go through security in the airport, for example, that's not really a significant risk factor. And normal diagnostic radiation, including mammograms, are not consequential in terms of any risks. Breast density is a hot topic of investigation now. About 40% of American women have dense breasts. Breast density is not the way they feel. Breast density is the way they look on a mammogram. It's not totally clear whether it's a risk factor for having a higher incidence of breast cancer or it's just harder to diagnose on a mammogram. And we'll be able to sort this out a little further as we go to more sophisticated screening tests for breast cancer. Estrogen exposure is a clear risk factor. Women who take postmenopausal estrogen replacement therapy or women who've had a long exposure to birth control pills in their premenopausal years clearly have a higher incidence. In hormone replacement therapy, it's the estrogen progesterone combination. It's not clear that pure estrogen, for example, in women who've had hysterectomies, that estrogen by itself increases risk. That is not clear. But for women with attacked ovary, and attacked uterus, we're taking estrogen and progesterone, and you need progesterone there to reduce the risk of getting uterine cancer. Those women are at considerably higher risk, and we've got very firm data substantiating that. For limitations of time, I can't go into it, but it's very, very clear. Of interest is that the incidence of breast cancer is higher in white Americans, but that the incidence of breast cancer deaths is higher in Black Americans. And you can see that there's a breakdown by these ethnic and ancestral, genetic classifications, as you see here. Part of the reason is that if you look at the kinds of breast cancer that people get, you can see that African American women or Black women have a much higher incidence of a kind of breast cancer that's called triple negative, negative for hormone receptors and negative for HER2. And this is a very important topic of investigation right now, why this is so. It's not because of known cancer predisposition genes. BRCA1 and BRCA2 are the most common major breast cancer predisposition genes. And you can see AA is African American, EA is European American. You can see there's not really much of a difference there in that regard. And the other genes, PALB2, ATM, CHEK2, there are differences in Europeans, Americans, there are more CHEK2 mutations than there are in African Americans. African Americans have a scattering. Part of this, and I wish I could show you the data here, that is part of the confusion is that there is no pure European American or pure African American. African Americans vary in their genes. Some people who are self-identified as Black, for example, have genetic profiles that are identical to people who self-identify as European, for example. Others are much closer to the genetic profiles that we see in people who are still living in Africa. So there's a tremendous variation here, and there too, with people who self-classify as Latino, for example, Latina, is that there's a strong admixture of Native Americans, a strong admixture with African Americans and European Americans. So the whole idea of race is a very, very muddled thing. A lot of it is self-identified or imposed upon people by the majority population. However, the higher incidence of triple negative breast cancer in African Americans is not all accounted for by differences that we could discern, let's say, in terms of environmental exposure. So I just wanted to go through this because I think this is very relevant to comparative oncology that we're going to be talking about later. Let's say you have a population of people, let's say in Europe. These are humans in Europe. And by random chance, there's a founder mutation that there's a mutation that occurs in one person who passes that on to the genes, but they're very rare. Now, let's say there's some event that reduces the population. For Ashkenazi Jews, that would be murder, pogroms, for example, or assimilation, both being very effective factors that reduce the size of the Ashkenazi Jewish population. So that population then, when they, let's say, move to America or even in Europe, when they expand, that rare founder mutation can become enriched in the population and be more common. So BRCA1, BRCA2, and Ashkenazi Jews would be an example of this happening. Another way is that if people are forcibly removed from the population, selected, and then go to another place, let's say from Africa to North America, where they're selected, and just by random chance, that founder mutation is in that population. So when that population expands, they will have a higher incidence, their progeny will have a higher incidence of that. And this could be some genes that we don't know about yet, not BRCA1, BRCA2. I've showed you that's not major differences, but other genes or combinations of genes. So this is a very, very important thing that we're studying right now very intensively in a whole variety of ways to see why is it that African Americans or people who self-classify as Black have a higher incidence of this triple negative breast cancer. Is there a genetic link there? We'll talk more about that in my last slide. Now, just to do a lightning tour of breast cancer diagnosis is the best way is by some form of imaging. And most of the breast, as you already know, you're all in the medical field, is fatty tissue. Breast cancers all occur, I think in humans and in animals, other mammals, at the place where the ducts meet the lobules, that particular little spot called the ductal lobular terminal unit. is the place where all breast cancers arise. So a fairly small number of cells are really are the origin of breast cancers. We recommend at Memorial and many others starting annual mammograms at age 40. It's not really, we don't consider it a controversial topic, although it's a very actively discussed topic in the popular press, and there'd be questions about that. We made huge advances in our ability to actually diagnose breast cancer by mammograms. Here's a conventional digital, what we call 2D mammogram, and you see that whitish material there is actually the breast tissue. The darker material is just the fat that the breast tissue is in. However, if you do what's called tomosynthesis, so a three-dimensional cut of the breast, you can see that there's a breast cancer here, which was totally missed if you didn't do the tomosynthesis. And we have other improved techniques that are coming into common use called contrast enhanced mammography, for example, that's finding much smaller tumors and tumors that would be missed with older techniques. We could also supplement with ultrasound. Ultrasound helps, particularly with people with dense breasts. It's not as good as MRIs that I'll mention in a second, but it's particularly useful if you feel something abnormal to get a good picture of what it is. And we can tell if it's fat necrosis or if it's a lymph node, a benign lymph node. So ultrasound does give us a good picture when we need it. This would be a typical image of a breast cancer that we would see on an ultrasound. It's just basically a shadow because the sound waves bounce off it differently than they do with the fatty tissue of the breast. MRIs are much better. A woman lies on a machine and she goes face down and she goes into the machine. Her head is actually sticking out. So claustrophobia is not such a big issue as it used to be with some of the older machines in this particular regard. And this gives you a much better picture of the breast. This is happens to be a large breast cancer on an MRI, and you can see it's really very obvious. So this has become a very, very useful technique in humans. Physical examination by a professional helps somewhat. Self-exam has never been shown by trials to help. It's a very hard thing to study. However, we still recommend that people know what their breasts feel like, so if they feel an abnormality, they can call the attention of a professional. I must tell you that I have picked up breast cancers that have been invisible by mammography and and other techniques where the breast feels different to me, and then we go further and we do mostly MRIs to actually find the lesion. So professional exam can actually be useful in the right hands. Classifications of breast cancer. This, as I said, it's the place where the duct meets the lobule, where they all arise. This would be a normal, what that area would normally look like. Then you get changes such as ductal hyperplasia, which is really a benign finding. When it's atypical ductal hyperplasia, it's also benign. You can't die from atypical ductal hyperplasia, but women with heavy atypical ductal hyperplasia have a higher incidence of about 4 or 5-fold of coming breast cancer later on at some time in their life. This can progress to something called ductal carcinoma in situ, which is still not a breast cancer, even though it has the word carcinoma in it. But these are abnormal cells that look like cancer cells, but they're in the duct and they're not spreading. There's two kinds. There's ductal carcinoma in situ and there's lobular carcinoma in situ, where they look like lobular cells in this regard. And these women do have a much higher incidence of breast cancer, so it has to be removed. And often we do radiation to the rest of the breast if the patient just has a lumpectomy, for example, and we may want to give them hormone treatments to lower their risk of breast cancer. So this is a predisposing lesion, but a significant one. And then you get true invasive breast cancer. Now, if ductal carcinoma in situ is called stage 0, in the very beginning of breast cancer, the breast is called stage 1. It's a small lump, and it's a lump that doesn't involve lymph nodes. If the lump is bigger or involves lymph nodes, we call it stage 2. Stage 3 is locally advanced disease. Stage 2 and stage 3 are now commonly given drugs before we operate on them to shrink them down, make the operation easier, and also determine if the cancer is sensitive to the drugs, because if not, we may use additional drugs. And of course, the really serious part is spread of the cancer and metastatic disease to really any part of the body, as I've already mentioned. There's been a big evolution of therapy in humans for breast cancer. It used to be removal of the breast and the associated lymph nodes, the radical mastectomy. Then it became a modified radical mastectomy. In the old days, we used to actually remove the muscle of the chest wall to get as much of that tissue out as possible. That's been shown to be unnecessary. Just removing the fatty tissue of the breast and examining lymph nodes is enough. And we've evolved something called breast conserving surgery, the so-called lumpectomy, where you just remove the tumor to clear margins. Uh, One of the biggest advances in my lifetime for breast cancer is something called sentinel lymph node mapping, where you can put a dye into the breast, into the tissue of the breast, and find out if any lymph nodes pick up the dye and take those lymph nodes out. If they're negative, you know you don't have to do any more axillary surgery. We treat with various treatments in the breast to try to reduce the risk of metastatic disease. One of the most important things to know is that we've made major advances in the molecular characterization of tumors now by looking at the genes that are turned on and turned off. I can't go into this in detail, obviously, but we can classify cancers by those genes, and this definitely influences our choice of therapy. We can go even further with this by looking at subsets of genes. Particularly, there's a test we use commonly called the Oncotype DX test, which looks at estrogen receptor positive breast cancer by these genes. And we can use this to allocate patients to the setting where we can, where the patient, how did this happen? Where the patient will benefit from chemotherapy or not. Since these tumors are all estrogen receptor positive, they all receive hormone therapy. Those patients receive hormone therapy, but you can see the patients who have negative lymph nodes but have a high score on those genes benefit from chemotherapy as well. Patients with positive lymph nodes, too, we can allocate them to risk categories by whether they have a high score or not. And so many patients now, and it varies by premenopausal, postmenopausal, can't go into those details, but we use that molecular information. And we're finding that the majority of patients with estrogen receptor positive disease do not need chemotherapy now, because we can allocate them to this particular, risk groups where hormone therapy is enough to give them a good prognosis. We use all these factors, and in addition to that, we use hormone receptors. Hormone receptor positive, HER2 is another molecule we measure in the breast cancer, and about a third of breast cancers, quarter to a third, have HER2. And we use this to allocate patients to therapies, estrogen therapies of various sorts, inhibitors of mechanisms of resistance to hormone therapy of various sorts. We can use chemotherapy in estrogen receptor negative disease and in estrogen receptor positive disease that have a high Oncotype score, or in the metastatic setting, which we'll get to in a second. Inhibitors of that HER2, very common. Now we have antibody drug conjugates that can bring antibodies that can bring the therapy right to the breast cancer, a huge advance, particularly in the setting of metastatic disease. In patients with BRCA1 defects, we can use drugs that take advantage of the fact those cells can't repair their DNA and the cells can go on to die. Immunotherapy is starting to emerge as a useful treatment, particularly for estrogen receptor negative, what's called the triple negative category of disease, and bone therapies to make the bone stronger so that you reduce the incidence of the cancer metastasizing to bone. If we give these drugs right after surgery, we can lower the estrogen receptor positive cancers, we can lower their chances of the cancer coming back, and estrogen receptor negative cancers, and even in the positive cancers, giving chemotherapy drugs that can kill cancer cells can also lower the chance of the cancer coming back. Which one we use when, as I say, we're using a lot of molecular characteristics to make that distinction. If the cancer happens to be metastatic, then everything I've said before about the drug therapy applies, but we have other therapies, and allocating patients to the appropriate therapy for the metastatic disease is a very sophisticated science now. We have to take into account all the factors that we mentioned and the molecular characteristics. We have many drugs that we can use. And obviously, I'm not going to go over this, but just to say that immunotherapy and bone strengthening agents and specific therapy for hormone for things like HER2, these antibody drug conjugates, is a very complicated, sophisticated field, but we've gotten very good at giving the right therapy to the right patient, and this is a field that's constantly getting better, and we're learning more and more over time. I want to end by just mentioning the linkage between the genetic stuff that I just mentioned before and veterinary oncology in this regard. I thought, to show you how bad I would be in your field, I thought these were dogs, but now I'm told they're really bears. I apologize for my ignorance in this regard. So imagine they're dogs for a second. Let's imagine we have a whole lot of wild dogs. And let's say that we want to select some of those dogs for certain characteristics, all right, or say these are racehorses, we want to select them for speed, or we want to select dogs for their hunting ability, we want to select dogs for their cuteness to at-home pets. And so we just select them. I put a little flower on the ones we want to select, and we select them. And then imagine that that expands, that population expands. Now we have a whole lot of cute dogs, and people are going to want to have them in their homes, and we're going to have a whole lot of pets. But what if in this act of selection, that accidentally we also have some genes in there that are deleterious, such as genes that may predispose to breast cancer? Now we have an enriched population with a higher incidence of breast cancer. And one of the things that I am most impressed with from veterinary medicine is the fact is that there's a different incidence of breast cancer and other cancers in different dog species and in different animals. And Nicole can talk much more about that in a much more sophisticated way about that. So that in fact that there are genes in there that actually are predisposing. And we don't know too much about that, or at least that hasn't been translated into human oncology. And just as we're trying to study why is it that people who trace their ancestry to Africa may have a higher incidence of a more serious breast cancer triple negative, why is it that certain animals have a higher incidence of cancer? There's a really fertile field here for trying to find out what are the molecular genetic underpinnings of cancer, and it could help us take care of animals with cancer and prevent cancer in animals. It could also help us in the human situation. So I think this is a very, very fertile field that we should be talking about, and it's an area where much more cross fertilization I think could be beneficial for our two fields. Thank you all very much for listening. I will stop screen sharing, and now I'm looking forward to hearing Nicole's presentation.
Thank you, Dr. Norton. Okay, let's just get set up for Dr. Leibman, and then she'll go ahead and present to us.
Hi, everyone. I've had the great good fortune of spending my entire career at the Animal Medical Center, and I'm really elated tonight to be here as an ambassador for the institution. I'm honored and humbled to speak alongside Dr. Norton. I'm so proud to call him my colleague and my dear friend. Thanks for being here tonight, Larry.
Thank you.
So I am going to speak about feline mammary tumors to start. I'm having a little bit of a, so this is the third most common tumor in cats after skin tumors and lymphoma. Unlike women and dogs, almost all cat breast tumors are very malignant, and they're almost always hormone independent, but we can talk about that in a second. Median age is about 10 years. The Siamese is predisposed, and about only 10% will express estrogen receptors. If we spay them before their first heat, they have an 8 times decreased risk of mammary tumors. Strong association with the use of progestins. Often these tumors are not detected until they're very large, and they may ulcerate and ooze fluid, as you can see in this cat's inguinal region. That's a very aggressive inflammatory tumor. Fibroepithelial hyperplasia is a disease that young cats get that are treated with progestins or during pregnancy. These glands can be enlarged. Usually it's just one gland. They can be edematous, and the differential diagnosis is mastitis. The best treatment is spay, and the flank approach may be indicated. So as you can see here, adenocarcinoma under the microscope, pathology is the most common histologic subtype, highly metastatic to every organ there is. Generally, though, the lungs are the most common that we see. For pulmonary metastatic disease, as you can see here, my pointer is not working perfectly, but in the caudal lung field, you can see a pulmonary metastatic lesion secondary to a primary breast tumor in the cat. And here, this is more advanced pulmonary metastatic disease in the cat. It has this really sort of feathery, cottony experience that you can see here. In the dog, it's much more nodular appearing. So as far as staging, it's similar to what we do in dogs, not as advanced as what we do in people. Cats always need to be retroviral tested because that always is a game changer, especially when it comes to therapy. They're much more sensitive. Although feline leukemia in and of itself is not shown to play a role in this particular tumorigenesis. Thyroid is always important to evaluate, and full body CT is what we generally do at this institution. Radical mastectomy is certainly what's indicated. It's not always practical. It's an expensive procedure. It's a lot for the cat to go through. It's still controversial whether we should do bilateral or unilateral mastectomies. They generally need to be staged. It's very difficult to remove all of the mammary glands on one side as well as the other in one surgical procedure. It's difficult to close the skin. So we generally stage them. We do one side, and 6 weeks later, we'll do the other side after it's healed. We know that disease-free interval is 575 days versus 325 days with conservative surgery. So for radical mastectomy, we also always want to make sure to tell our surgeons to remove the inguinal nodes and the axillary nodes. And it's very important when you send your samples off to pathology that if the pathology comes back without lymph nodes being evaluated, that you nudge your pathologist to go back, dissect out the nodes and evaluate them, because that is very important for prognosis. It's important with this surgical procedure to consider referral. Often body wall reconstruction is indicated, and this is a very, very complicated surgery. Pain medication is indicated and necessary after surgery, and in an ICU setting is really what's best for the animal to recover in. So these are some photos of a radical mastectomy in the cat. And as you can see on the lower two photographs, on the left is the entire mammary chain, one side of a mammary chain removed, and on the right side is the mammary chain inked. And you want to make sure that the entire cut edge is always inked so we can identify for any sort of tumor cells that are left behind, which then will lead us to what our therapeutic plan may be. For histopathology, the most important aspects are the completeness of excision, and that's tricky. It's not just clean or dirty, right? We need to know how clean the cut sample is. And so if a pathology report is returned to you and it says clean margins, it's very important that you go back, you talk to your pathologist, and you ask them how clean. 1 millimeter is not clean. That is not clean. There is no magic number here. We love 5 millimeters. That makes us happy. There are certain instances where we have to accept 3, but 1 millimeter, and certainly less than 1 millimeter, is really not a clean margin. There certainly can be tumor cells outside of that cut area. And then of course, we never want to see vascular or lymphatic invasion. That is a negative prognostic factor. So here, under the microscope, you can see on these two photographs, you can see vascular and lymphatic invasion. All of those purple cells are cancer cells that are in the vascular space. So prognosis for feline breast cancer, 2 out of 3 recur after conservative surgery. So back to what I was saying before, it's really, really important if these people are in it to win it to consider radical mastectomy. Lymph node involvement certainly carries a worse prognosis, and we often don't know that until we've already done our radical mastectomy. We should try as often as we can to identify those lymph nodes pre-operatively. We need to evaluate them if we can via cytology, and if there's already lymph node involvement, then we know that we are not going for a cure or even a long-term survival, and then our treatment plan will definitely pivot. Patients presenting with metastasis rarely have long-term survivals. Domestic short hairs have a positive that is a positive prognostic factor, and size of tumor is highly prognostic, and this speaks to stage. So anything less than 2 or less than 3 centimeters is a stage 1, and the median survival time is greater than 3 years, and it goes down from there. And when we get to a tumor that is 3 to 5 centimeters, the median survival time is only 4 to 6 months. Stage 4 is when the tumor is already metastasized to a lymph node, and stage 5 is when it has distant metastases. So for therapy, 50% of cats, according to one paper, with non-resectable disease had a response to doxorubicin. NSAIDs don't work so well here, although we use them for other carcinomas, since 0% of COX-2 expression was demonstrated in feline breast cancer. We generally recommend chemo in most cases. Radiation is always an option. Also, it certainly can be a big undertaking, but we certainly can utilize radiation in these cases, and we need lots more prospective trials. So now I'm going to speak about one of my all-time favorite cases, who belongs to one of my all-time favorite families. We've treated multiple cats belonging to this family, and this was Sweet Magic. She was an 11-year-old female spayed domestic short hair. This is a happy story. It just was a story that happened a while ago. So I'm not going to tell you a sad story. I'm going to tell you a happy story. She had a history of stomatitis, and then the owner recognized a mass in her breast area. Fine needle aspirate or cytology demonstrated a cystic structure. Chest radiographs and an abdominal ultrasound had no significant findings, and the owner had declined a CAT scan at this time. The surgical service recommended a radical mastectomy with possible bilateral radical mastectomy. This owner is, she takes care of lots of feral cats. They're really, they're amazing people that take care of lots and lots of animals. So for financial purposes, they elected mammectomy instead of radical mastectomy. On the biopsy, there was a mildly invasive mammary basaloid apocrine ductular adenocarcinoma. There was a high nuclear to cytoplasm ratio, although there was no vascular invasion. The margins were good. She got doxorubicin. She got 5 doses of that, and she completed chemo 6 months after diagnosis. She had pulmonary metastatic disease 14 months after diagnosis and 9 months after completing her doxorubicin. The owners were offered additional chemo with carboplatin versus cyclophosphamide or toceranib phosphate, which is a small molecule inhibitor. So these are 2 CAT scans. Both demonstrate pulmonary metastatic disease. The one on the left is from a dog in the upper right-hand corner. So it's reversed, but you can see the R on the left side of the screen, and on the top of the right lung there is a pale nodule that is a metastatic lesion. On the right side demonstrates the difference between feline and canine pulmonary metastatic disease. You can see it's a lot more wispy, it's less defined. In the middle of the right lung lobe there, you can see a nodule, and then in the upper part of the right lung lobe, you can see a nodule also. So I'm going to switch gears quickly and talk a little bit about KIT or CD117. This is a proto-oncogene that encodes for the KIT protein. This is going to relate to Palladia, or the drug that was ultimately used for MAGIC for years to come. It's a transmembrane tyrosine kinase inhibitor, and this is present on mast cells, interstitial cells of Cajal, and stem cells. In mast cells, specifically, it promotes mostly proliferation. We don't need to go through all of this, but this is how this drug was initially licensed, was for use in mast cell tumors. In canine mast cell tumors, mutation of this protein c-KIT causes constitutive activation in a pretty high percentage of tumors. So this is a PCR gel, and you can see that under the M lane, the mutation lane, you can see the mutation, the amplified c-KIT. And this is a busy slide, but I wanted to point out exon 8 and exon 11 here, which are the two exons that we test for. Exon 11 is prognostic for canine mast cell tumors, and exon 8, if they're positive, at least allows us to know that this small molecule inhibitor will be more effective. So tyrosine phosphate, or Palladia, which is a tyrosine kinase inhibitor, is indicated for the treatment of recurrent cutaneous grade 2 or grade 3 mast cell tumors with or without regional lymph node spread. But we also use it, and there are now papers published for the use in carcinomas, sarcomas in both cats and dogs. It inhibits KIT on tumor cells for an anti-proliferative effect. So it slows down the proliferation or the growth of these tumors. It also, we know that these small molecule inhibitors, this is considered a dirty small molecule inhibitor. It inhibits VEGF and PDGFR for an anti-angiogenic effect. So the response rate for canine mast cell tumors is better if they have this mutation with the use of Palladia. So for Magic, back to Magic, her chest radiographs every 3 months continued to be stable. 2 years after her diagnosis and 10 months after starting Palladia, which we did, her tumor nodules in her lungs decreased in size. So on the left is a radiograph pre-Palladia, and there's some nodules in the caudal lung lobe, and 10 months after starting Palladia, fairly stable. The radiograph on the left is pre-Palladia, and on the right is slightly progressive disease, as you can see the nodules, especially in the right lung area. On the left is 1 year after starting Palladia, and slightly progressive disease 2 years later. So this drug was really a miracle for this cat. 4 years after diagnosis on the left and 33 months after developing metastatic disease and starting Palladia. And then on the right, continued progressive disease for almost 5 years, but clinically well. So that was a very, very optimistic and great case to work on, because not only did Magic teach us how effective Palladia can be for metastatic disease in cats, we hardly ever see our patients live that long. So that was a really great case for all of us to be involved with. So now I'm going to switch gears to canine mammary tumors. It is the most common tumor in sexually intact female dogs. 16 to 18% of all dogs age 8 to 10 will develop a breast tumor. This disease is much less common in the United States due to the common practice of spay. So risk factors, and Dr. Norton spoke very eloquently about the risk factors in women, and some of them are the same in dogs and some of them are different. I mean, we don't spay women, thankfully, but we do spay dogs. And if we spay them before their first heat, they have a 0.5% overall lifetime risk of developing breast cancer, so almost zero. Before their second heat, it's about 8%, and before their third heat, it's 26%. There is data to support that if you spay them anytime after this, there's no additional benefit. There is some data published now that really urges veterinarians to wait till after the first heat, especially in larger breed dogs, Rottweilers, because it can help with bone development and decrease arthritis later on in life. And also it decreases the incidence of urinary tract infections, so their vulva completely matures due to the estrogen involvement in helping that organ mature. Newer study that's been published shows a decreased risk of breast cancer when spayed during tumor removal. This was mostly involved benign tumors, but there was some mention of malignant tumors also. As far as breeds that are predisposed, we mostly see breast cancer in smaller breeds, poodles, chihuahuas, Yorkies. We know that progestins increase the risk of breast cancer in dogs as they do in cats, and body weight, which Dr. Norton also referred to. So we know that animals that are thin during puberty have a better chance of living a life without developing breast cancer. And we know that fat helps to trap estrogen, and estrogen drives breast cancer. It's one of the reasons that breast cancer can develop. And a diet high in red meat can also be a predisposing factor for dogs developing breast cancer. So a little bit about hormone status. We know a lot less about it in animals than our human counterparts do. We know that tumors in younger dogs tend to be hormone receptor positive. Benign tumors are more likely to be positive. Smaller tumors, well-differentiated tumors. But we do see this biologic drift, if you will, where as tumors become larger and more poorly differentiated and more aggressive, they become more hormone independent. So as far as comparative oncology, this is not my area of expertise. I'll speak quickly on it. We know that mutations in women for BRCA1 and BRCA2, 5 to 10% of all breast cancers in women will have these mutations, and it's an overall 85% cumulative risk over their lifetime. BRCA1 and BRCA2 have been associated with an increased risk in English Springer Spaniels, and these studies are really limited. BRCA1 was shown to be underexpressed in malignant tumors and overexpressed in metastatic disease in dogs. Talk very quickly about HER2. In 20 to 25% of human breast cancer that's resistant to hormonal treatment and with an aggressive course. We know that HER2 expression demonstrates mixed results in canine breast cancer. Differences are related to protocols and scoring systems. We're still very young in understanding all of this. Women are treated based on molecular testing, subtype on biopsy, grading and staging. Molecular testing of breast cancer in dogs with human immunohistochemistry are ongoing. These studies, ultimately using molecular diagnostics to plan precision medicine, is where we all hope to be. We're behind the human field. We don't have the support that our MD counterparts do, but we're getting there. And we are trying very hard to catch up. So I will just end with this slide, which is a slide of a canine and human normal breast tissue. And on the bottom, you can see the tumor cells in purple, the carcinoma in the canine and in the woman. And I'll stop there and we can take some questions. Thank you.
Great. All right. So we already have one question in the chat. Just a reminder, if you want to ask a question to Dr. Leibman or Dr. Norton, please put your questions in the chat and I'll go ahead and read them. This one seems like it's for Dr. Norton. It says, do recommendations for mammograms change in frequency in postmenopausal women? I've heard differing frequencies, every 1 or every 2 years.
Yeah, there are different guidelines out there. They largely vary because of the there's no new data, by the way. I mean, that everything we know about mammography in humans is based on old mammographic studies, mammogram studies that have been reviewed and reanalyzed many times over the years. That if your endpoint is a cost effectiveness endpoint, if your endpoint is how few mammograms can you do and still get a reasonably good result in a population, and fewer mammograms therefore reducing the cost of doing the mammograms, then you can start getting into doing less than once a year. If your goal is to minimize the risks of a woman dying of breast cancer, then the right answer is annual starting at age 40. Should you ever stop doing mammograms? I never stopped doing mammograms in women of any age, because even though it may be very hard, people in their 80s, or advanced 80s demonstrate that diagnosis of breast cancer is going to change their survival, because for the most part, you can survive a long time with breast cancer, even in the metastatic setting. Older people tend to have estrogen receptor positive disease. You could treat that. Certainly, finding the cancer earlier enables you to save breasts. So I say it may not save your life, but it will save your breast, because you do breast conserving surgery, which is a very significant advance for most people, to go that route. So I never really stop in that direction. So everything else is really, cost effectiveness. When they talk about the harms of mammography, and a lot of people say, we have to talk about the benefits and the harms. The harms they're talking about is having to get a needle biopsy to prove that you don't get cancer. That's considered a harm. I don't know anybody who's been upset after we do a needle biopsy, and prove that it's not a cancer. They're usually very happy at that particular moment. Or the anxiety of worrying about, do you have cancer or not, until it's proven not to be cancer. But you compare that to the benefits, which is saving your breast or saving your life, and I think there's a total imbalance between when we talk about benefits and harms in that setting. So Memorial, we feel very strongly, is that annual mammography starting age 40 is the way to go. Now, people at higher risk for one reason or another, prior biopsies showing atypia, for example, or a known breast cancer predisposing gene mutation, then we may do, or very dense breasts where a mammogram doesn't give you a clear picture, then we may do other things, such as mammogram plus sonogram, or MRI, or the newer test, which I'm a big fan of, called contrast enhanced mammography. But when we're talking about mammograms, annual mammograms, we're talking about people at average risk, not at a higher risk.
Okay, we've got quite a lot of questions tonight. This one's for Dr. Leibman. Are PET scans accessible for veterinarians?
Yeah, I wish that they were. There are institutions that do them, and there are institutions that use human facilities to perform PET scans. I know Colorado State has a PET scan. I think Tennessee has a PET scan, and there are certainly institutions, again, like I said, that are utilizing human institutions at night or on weekends to use their PET CTs. So it's a very expensive machine, and it requires a big investment. We're getting there. That's the best I can say. So again, there's none on the East Coast here that we have access to.
Okay. For Dr. Norton, is mammary ductoscopy being utilized for early detection in human medicine?
No, it's been studied a lot, and they just miss a lot of lesions. And so actually doing ductograms, where you inject dye into the ducts, or actually going into the ducts with, like you do a colonoscopy, which can be done. First of all, you have to be really sedated, because it can be really painful. And secondly, you just miss a lot of lesions. So there's no modern role for those techniques.
In dogs, inflammatory mammary carcinomas, inflammatory breast cancer are very hard to treat. What are the treatment options for people?
Oh, for people, yeah, inflammatory breast cancer is on the rare side of breast cancer, and that it's called inflammatory because it looks like the breast is infected. It's red. The skin may be involved with the tumor. Those patients you don't operate on those patients right away. They need to shrink the tumor down before you operate. And almost always we have to use chemotherapy in that particular setting, and not just one drug. Nicole mentioned doxorubicin, adriamycin is a drug. We use combination chemotherapy. We've gotten sophisticated with doses and schedules, in that particular regard. Also, if the tumor is triple negative, we may add immunotherapy in that setting. But the response rates can be very good, and you can actually get considerable shrinkage there. And I was actually wondering, as a question I have for Dr. Leibman, is that maybe we should be using more neoadjuvant chemotherapy in these. I saw some pictures of cats with very, very big advanced fungating tumors, that it might make the surgery a whole lot easier to actually get a preoperative shrinkage of that tumor, and then may even improve prognosis. So I'm wondering whether there's any thought in animals with very large tumors when they presented, giving
Yeah.
drugs before you operate.
I think the issue with neoadjuvant therapy in this setting is that, the dose of drugs that we use is very different than the dose of doxorubicin in women, I think, is 70 milligrams per meter squared. So in dogs, we use 30 milligrams per meter squared. As a community, we all agree that we don't want our chemo patients hospitalized for chemotherapy associated toxicity. So we don't see a lot of tumor, response with, gross measurable carcinoma. What we have used in this setting is radiation. And I've seen some really nice measurable responses with large, dose per fraction or coarse fractionation to shrink very inflammatory tumors. And then we can discuss and think about surgery.
Okay, the next question is for both of you. It says, does MSK and AMC use AI for patients to determine cancer risks for humans and animals? What is your confidence level regarding AI data test results?
I'm not sure the question. They mean AI in terms of interpretation of the mammograms, or AI in terms of risk assessment? I'm not sure of
I
of
think
the question.
I think they mean both. Probably risk
Yeah.
assessment and then interpreting the imaging results.
Well, using AI, I'm not talking about generative AI here, obviously, using the, machine learning for analyzing large data sets. It's becoming a very active field of investigation, particularly in the area of molecular characterization. When you look at hundreds of genes with mutations and amplifications and translocations, can you actually derive more information from that than you can from the simple, one-off that we're currently using, basically, of this gene is abnormal, so it leads to an abnormal situation. So the analysis of molecular data, it's a very active and exciting area of investigation at the present time. I also think, and this is just a little bit far-fetched, is that when we start to actually apply AI tools to populations, and population information in general, we may find that there are risk factors of breast cancer that we don't know about, because we don't have hypotheses that would actually take us from those factors. For example, it took us hundreds of years to figure out that cigarette smoking was associated with lung cancer. That would have immediately popped out of an AI analysis of populations, to find that, the ones who are using cigarettes have a higher incidence of, of lung cancer. It would have taken a few seconds for modern AI tools to find that. Yet it took us centuries to find that because we didn't have an underlying hypothesis to look for that. So it may be things that we're doing in our normal lives, things we're eating, behaviors, sleep patterns, things that we don't even know about that may actually be associated with breast cancer risk. And I think AI is going to give us a lot of information there. On the imaging side, AI-assisted mammographic or MRI interpretation is a common area now. I mean, there are lots of tools that people are applying. A lot of radiologists are using that actually to augment. They call it CAD, computer-assisted diagnosis, of analyzing mammograms. We do it. We consider it still experimental in human disease of remorse lung Kettering, but there are very exciting tools now that where we can plug a mammogram into an AI process and actually predict the likelihood that that breast will form a breast cancer in the next year or two. And that could be extremely useful for actually scrutinizing patients more carefully, examining them more carefully, maybe even doing more often evaluations in that particular setting. So it's just the infancy of the application of AI tools to this whole area, but it is a very exciting area of investigation.
Do you have anything you want to add to that, Dr. Leibman?
As I've been saying, we are trying to get there, but our radiology team is starting to explore AI tools, and we're hopeful that we will have that ability soon, be able to help with reading our imaging and sort of streamlining it. So that is soon to come. So stay tuned.
Okay, we have two more questions. For low-grade breast cancer, not metastatic, just lumpectomy, I hear a lot of concerns of the benefit of chemotherapy to prevent recurrence versus reported side effects.
Well, that's where, I mean, it's an area we need an expert. That's what we do, to allocate who gets what. As I showed you, we're using molecular characterization a lot in that regard. But you say it's a small estrogen receptor positive breast cancer, negative lymph nodes, hormone therapies like tamoxifen or aromatase inhibitors would be useful. Why would you add chemotherapy? Well, sometimes we see with cancers that look great under the microscope and they all their clinical characteristics are small. When we do that oncotype test, they come out with a high oncotype test. And clearly the research has shown, prospective randomized research has shown that when you have a high oncotype, even though the cancer looks small and looks like it's a good prognosis cancer, it actually has a high risk of developing metastases and should be treated more aggressively, i.e. the use of chemotherapy. There we have many different kinds of chemotherapy. We don't use, it's not one size fits all. We have to actually, give the right chemotherapy to the right patient depending upon risks. But that's where the molecular diagnostics comes in a big way, because you can use those to actually not only find that most patients don't need chemotherapy, they got a good prognosis with hormone therapy alone, and save those patients chemotherapy. But indeed, you can find some cases that in past years we'd say, hey, this patient absolutely doesn't need chemotherapy, hormone therapy is enough, and you could actually pick out ones that actually do benefit a lot from chemotherapy.
And this last question is for Dr. Leibman. Would you recommend chemo for cats with early stage, non-metastatic, grade 1 mammary carcinoma?
I do. We always recommend chemotherapy for any breast tumor in cats. I mean, I've seen a lot of breast cancer during my career in cats, much more than I've seen in dogs. And I have to tell you, more often than not, even the few low-grade tumors that we see end up metastasizing. So yes, we recommend chemotherapy in all feline breast cancer.
Is that because you're diagnosing them late, or as opposed to in humans because you're not doing mammograms on cats?
Right. So every bit of breast cancer that we diagnose in small animals is palpable, right? And
Right.
often, not small. It's often 3 to 5 centimeters by the time we see the mass. So we don't diagnose anything microscopic. So anyway, thank you so much. This has been a great pleasure to be able to speak with you and to all of you.
Yeah, thank you everyone for joining us tonight. The link in the chat box, or you can scan the QR code to submit your CE request. Certificates of attendance will go out on Wednesday, November 20th. And then next week's topic will cover common cutaneous tumors, and we'll be joined by Dr. Anna Pavlik, as well as myself. So I hope to see you all there. Have a good night.
Thank you, everyone.
Thanks, everybody.